generate that. Just related to what Dr. Saad has just said, one of my patients who was a Pakistani by chance in UK, and usually the quality of Pakistani patients is very poor because they don't trust the system. They don't trust it here and they don't trust it over there either. And it was an old sort of elderly lady who had problem with anorexia and was not putting weight on. She was quite depressed. In fact, that's what my take on her was. I'd investigated her fully, done endoscopies and everything, and she was normal. And then when I saw her in clinic, her son insisted that I repeat an endoscopy, and I said, even if I repeated, I'd only done it 2 months ago, I'm not going to find anything different. And then he turned around to me and said, doctor, I want you to do it privately. And I really lost my cool with him. And I said, if you ask me to take her gallbladder out privately, just it's a normal gallbladder, do you think I would do that? And he said, yes. So I told him to, find another consultant who would do it for them privately, which I don't think anyone would have done that, without any indication. So it is not that you are getting paid for the procedure that you do it. You only do it if it is needed, because any procedure carries a certain amount of risk, a certain amount of discomfort to the patient, and it should not be carried out just for the sake of it or to make an extra few pounds.
I think there are three things creeping into the UK, predominantly now. One, patient complaints.
Yeah.
There are three things creeping into the UK very strongly. One is patient complaints.
Yeah.
And a lot of the time we're very frightened of the complaints. Now, I've got no problem sitting down in front of a patient and telling them that this procedure is not appropriate and I am not going to do it.
True.
But I can genuinely say at the same hospital there are 3 other doctors who wouldn't. They would sit there and they would say, okay, well, if you insist, I will do it, but
Yeah.
I know what the findings will be. And I personally think then you're opening up a can of worms, because if that's the one you perforate, then down the road.
You've had it.
That's one. 2, Dr. Google is increasingly becoming a problem. And
Yes.
Dr. Google winds me up no end. If you want Dr. Google, go and see Dr. Google.
Yeah.
But and then the next one is when we're looking at what patients are actually looking for, and it doesn't matter if it's their age as well. We have to actually look at the symptom itself.
Yeah.
And I think sometimes we become fixated on the symptom and saying it can't happen at this age. And sometimes we have to talk patients into a procedure rather than that, so it's our own prejudices as well.
Yeah. No, that's very true. Thank you, Paul. So, coming back to the indications, you can do colonoscopy for screening purposes, and screening is, there's a National Bowel Cancer Screening Program taking place in UK, and so it's part of that national screening program, as well as if somebody has got family history of colorectal cancer type syndrome, like familial adenomatous polyposis syndrome or the HNPCC or any of the other cancer family syndromes, then in those cases surveillance colonoscopies are indicated. Right, so surveillance is also carried out, apart from national screening programs, for anyone who has had a previous polyp or cancer resected. You would want to do surveillance on them. Inflammatory bowel disease, patient, whether they've had Crohn's disease or ulcerative colitis, should be part of surveillance after 10 years of the disease, and they should initially have it carried out every 3 years. After 20 years of the disease, it should be done on a 2-yearly basis, and after 30 years of the disease, on an annual basis. Unless the patient has got primary biliary cirrhosis along with the ulcerative colitis, in that case, colonoscopy should be done on an annual basis, because that is a high risk for developing colorectal cancer. A patient who have had erythrosigmoidostomy should have a surveillance colonoscopy carried out on a regular basis. Acromegaly, again, these patients are at high risk of developing colorectal cancer, so they should have surveillance carried out. Now, this is most important. In what circumstances is colonoscopy not indicated? Withdrawal of consent by competent patient. Once they withdraw consent, you can't do it. Endoscopists not accredited are incompetent to perform procedure. Colonoscopy is not for somebody who is just a part-time gastroenterologist or endoscopist. It is an invasive procedure with the potential to cause harm and it should not be performed by anyone who's not been properly trained to do it, because it involves a lot of discomfort to the patient. It exposes the patient to risk and should not be done by people who just do it for the sake of commercial reasons. Uncooperative patients are who cannot be safely sedated. Again, those should be referred to the specialist. Contraindications, again, acute severe colitis. If a patient has got acute severe colitis, you do not need a colonoscopy to diagnose that. That diagnosis should be made on clinical grounds only, right? And there are criteria for that. In acute severe colitis, the only thing that if you want to assess the activity of the disease, you can do a limited flexible sigmoidoscopy or rigid sigmoidoscopy on an unprepared or minimally prepared bowel. And that should be carried out by experts, not by somebody who's going to inflate the whole of his gut. Toxic megacolon is a definite contraindication to colonoscopy. Acute diverticulitis, acute abdomen of any sort, any acute perforation or acute abdomen of any sort is a definite contraindication to colonoscopy. Again, when you are assessing patients for indication or contraindication, the patient has to be assessed as a whole. And you have to remember that when you perform a colonoscopy, there are 3 different steps involved in the procedure. The first one is the bowel prep. Is the patient competent or well enough to take the bowel prep, which is quite horrendous stuff. You know, you give them 2 or 4 liters of movie prep or clean prep or Picolex, and then, you know, it's industrial grade laxative. They have to rush to the toilet back and forth. If the patient has got impaired mobility, he cannot move out of bed, is it appropriate to give them the full bowel prep at home, you know, unassisted? So all those factors have to be considered before you decide to book them for a colonoscopy. Sedation. If somebody has got severe limiting COPD or is in gross heart failure, whether he is able to take that sedation during the procedure or not. So those things have to be carefully evaluated. And again, the procedure itself, because it can be uncomfortable even in good hands, and the therapy that you carry out. So whether the patient is well enough to undergo those procedures. Complications arising from colonoscopy. Perforation. During diagnostic colonoscopy, perforation is extremely rare. The series I've quoted, 1 in 1,000, they are mixed diagnostic therapeutic procedures. If you take purely diagnostic colonoscopy, it should be extremely rare, otherwise you are doing something seriously wrong. Most perforations occur during therapeutic procedures, so usually polypectomy or treating angiodysplasia or stuff like that. And it can be due to sometimes a perforation of a diverticulum, or sometimes during acute severe colitis, the colonic mucosa, the colonic wall is quite friable and it can give way. Now, what are the factors which affect the outcome following any complication or, well, perforation in this case? And in case your patient is more elderly, the outcome, as would be expected, would be poor. A younger person would handle a perforation better. If they've got significant cardiovascular, cardiorespiratory comorbidity, their response would be worse. So they would take that badly. And all these things you pre-assess in there at the time of indication for colonoscopy. Delayed recognition of perforation. Sometimes you can get the perforation straight, you pick it up straight away at the time. The patient complains of severe pain, becomes distended, they lose their bowel sound, so you can admit them. Sometimes a perforation can be delayed, especially if you cause full thickness burns, which do not cause a perforation at the time, but can cause a perforation after 24, 48 hours at home. Then the outcome of that is usually worse because they get medical attention later. Delayed treatment. important thing about any complication is don't try to push it under the carpet. Always look for complications. If you recognize a complication early, you get medical attention straight away, you've not done anything wrong. It is all accepted. But people who try to hide their complications end up with bigger problems. So please do not try to, if you think that you might have caused a complication, always, err on the side of caution, because if I'm suspecting anyone who might have had a complication, I would rather admit him than send him home. Even if the next morning he's fine, it doesn't matter. Poor bowel prep, of course, if the bowel is not very well prepared, there'll be more contamination of the peritoneum or the abdominal cavity, and you have worse outcome.
Okay, just to say about the last point you were saying.
Yeah.
That you wouldn't mind, I wouldn't mind.
No.
But there are people who delay recognising a complication because they know the admission then goes against their name.
Yeah, I know.
They know it goes against their figures.
Yeah.
And those figures are then published locally and
I know.
regionally. And that's a big thing that's creeping in now into the UK, where people are very frightened of doing things. And I don't care, I will admit.
I am very similar. I don't give a damn about that, irrespective of.
I think if I can chip in here, in our setup, I mean, that's something that you want to put under the carpet.
Yeah.
Okay, generally.
Yeah.
There are two reasons. Not only just the fact that you don't want people to find out, but more importantly also because the cost is an issue. Okay. Because sometimes they're doing it in hospitals where patients are really hardly able to afford the cost, and then this adds the cost of it. So I think that is also a fear. But
Yeah.
The point I think that comes out very clearly here is that if you do that, then you're saving yourself a much bigger issue that would arise if they were to have a problem, continue living at home, and then come back to you in a messed up abdominal situation. So I think if you recognize the complication, it's important to immediately act, get your surgeons here, that's what we do, immediately involve the surgeon, so that you know that there is a colleague. Yes, of course, the colleague will start thinking, but then you have to have confidence that if the complication has occurred, if you're doing enough procedures, you will have complications. As long as they don't fall way above what is internationally accepted, you're fine. You will be taking difficult polyps. You will be diagnostic sometimes is very difficult problem. If you had a perforation, as long as you've not perforated every, you have a list of perforations like every 2 months or something like that, it's a different thing, depending on how many cases you're doing. But it's important to get somebody involved. If you're not comfortable, get somebody senior involved if you're junior. But don't try and put it under the carpet, because it will save you a lot of embarrassment in the future. One feels, you will say, but you don't save money. That patient ends up paying a lot more when he comes back later on. And that's one of the fears. Bowel prep is another issue that you just pointed out. Bowel prep is a big issue for us. I struggle. I have a patient who's come to have a procedure. Civil hospital is great, we don't charge, so we just say, come again. Here you have a person coming to a private sector, a bit being billed. There are charges, there are, of course, there's cost incurred. It's not due to their fault that their bowel prep is not good, and it's not due to my fault that my list is occupied. So it becomes a dilemma for us, and that's why we try and obviously if it's completely unseeable, and this is something that we will see during the course, then it's different. But otherwise, in my own practice, if I can see and watch and work my way out, way up to whatever I want to see, I will try and persevere because of this. And the other point I keep making in this course is that our females, there is a cultural issue that we have, even in males to an extent, but more importantly in females, that bringing them once is a problem. Bringing them second time is even a bigger problem. So that raises, rightly or wrongly, the threshold to persevere with bowel prep.
What do you use here, Saad?
Huh?
What do you use for bowel prep?
We use phosphate-based
All right, so
colonoscopy
Picolex,
solution.
yeah, okay, fine.
locally made, very nice things. We use Afan Hospital's things,
Yes, sir.
phosphate-based prep. And so basically what we do is, if we are at it, we might as well tell you, 24 hours of clear fluid diet,
Yeah.
and then a colonoscopy solution, which is 150 cc, mixed with whatever they like in clear rate.
Yeah.
They will have, if they are going to have a procedure this afternoon, then they would have one sachet at night in the evening, and the other sachet first thing in the morning, and then they will come back. Where people are constipated and I feel they will probably not take it, I almost always give them a clean animal.
Right.
Because I want to see the distal part, so
Sure.
I get reviews that way. But that's not always. Just standard bowel prep is this that we use. If it's a morning thing, then you actually have one in the morning, one in the afternoon, or, sort of late morning, and then one in the evening. Solutions, and then I think what needs to be avoided is you don't want them to have it at night and then remain awake all night, especially if they are elderly,
Yes.
well through to the room. So you need to time it that way. Most of our procedures, where most of my procedures outside here are done in the afternoon.
All right. So that's
So that's how it's done.
Yeah.
But in the mornings, I think we use that. But if that's not available, then you can use the standard laxatives. If for some reason you don't want to use that, then you can use something else. How good are our bowel prep? It really depends on how much time you spend with the patient. I think that's a very important factor, at least in our practice. You sit down and explain. We don't have the kind of nursing support and explanation that you have. So it's how much time you give. There are people trained, obviously, or takes inform the patients about preparation, and it has improved as they have improved their explanation. Because what happens is patients say, "Oh yeah," they always tell us, "Eat something."
yes, sir.
What the hell? But then what is going to happen tomorrow? Might as well have my last supper. So that kind of thing. But it's not as good as the bowel prep that you.
Yeah, because
I'll be
normally-
honest with you, you've seen last cases.
Yes, sir.
They weren't too bad,
No,
but
no, no.
they're not as good as especially sometimes
Yes.
in the right colon.
That's right.
When you reach the
Yes,
system,
sir.
you'll see a little bit of a coating, and that coating sometimes very difficult to wash even with the.
I think-
I use a phosphate enema endoscope, you see, when
Yes,
it's
sir.
or bowel prep, and that clears it.
Because,
that's something that we would like.
I think one of the things you are fortunate here that the colons are not as tortuous and redundant as they are in UK because so they're cleaner, much easier to clean
I
here.
tell you, you say that every time you're here, but I
Get caught.
I'm not too sure. The only thing that the only thing we don't have here, which sometimes makes it difficult, is the diverticular.
Yes, sir.
I think I don't know bowel prep. What bowel preps are you people using?
Our setup at JPMC, what we are doing is the same preparations in phosphate-based enema making, and our procedure timings are usually colonoscopy, the performance in or 12 midday. That's the time. So in routine, when we effectively ask them to report at 9 in the morning, and that time we use clean enema. Again, those patients who take it are usually good, well prepared, but the same thing you said that they don't care. They take half of them, they miss one of the doses, at night they want to, because we are doing it in the morning, they have to go at night to clear the amount. They miss the night dose, and for that matter, those are not very good. We have to do it.
You use
We use Dulcolax tablets
use Dulcolax. In addition to this,
daily.
in addition, so you're just using Dulcolax. So you use how many days?
4 tablets, 2 in the afternoon and 4 in the afternoon, 4 in the evening.
Okay, so you use Dulcolax instead of. Okay.
And if ready clean enema in the morning.
Right. Okay. Good.
One other thing, Vakar, is something that is important in elderly people. If you're using colonoscopy solution, if they don't have good support at home, I think it's important to admit them. That's
Yeah.
what my standard practice is.
Yeah.
They will be admitted, given prep in the hospital, and then do the colonoscopy. It's a one-day thing, have it done and send them home. So you don't want them going to the toilet having an accident of some sort, and especially if they're weak and frail. That's something that I do.
What about in partially affected cases?
Well, obviously then we use our clinical judgment, whether they should have a full bowel prep or not. I mean, that's why, evaluation.
You are sitting there and you are
Yes, sir. Yeah, well, if they're partially obstructed, they usually are inpatients, so they would have.
When you say partially obstructed, you
Yeah,
mean,
tumor.
but do
Oh,
they
tumors,
have signs of obstruction?
if they are not obstructed,
Then they're partially obstructed colon. They shouldn't have.
they shouldn't have a problem, because normally, like most of the patients with, CA colon who are not totally obstructed, they handle the bowel prep all right. And we use movie prep, which is polyethylene glycol solution as a routine, and that works very well.
They're different from this phosphate one.
That's totally different, yes. It's a non-absorbed, it just causes effect by osmosis. Yeah.
What about patients with bleeding? They have
Well, bleeding depends on how active the bleeding is. If, like sometimes I just get called out to scope somebody who's actively pouring out. In that case, bowel prep doesn't work. What we use is, I think Paul uses something different, but what we use is, one of our surgeons showed us a very clever idea. They use, I think in laparoscopic surgery, they use this pump for dissecting planes, which fires a jet of normal saline. You attach it to a drip. So we attach that same pump to our colonoscope, and as I just go, in the colon, wash it with liters and liters of fluid from that pump, and it works like a dream. So till you get to the point of the bleeding point and treat that. So that's what works for us. Otherwise, yes, if it's an elective procedure and you are going to do it, it's not actively bleeding, then we use our standard movie prep. But for acute emergencies, I use the pump.
What about the hypertensive patients?
Hyperten-
Phosphate solution?
No, we don't use phosphate, because for renal failure and hypertensive, those who you think might affect, we use the movie prep, which we use anyway normally.
Hypertension, I think it depends on how much you talk. I mean, what hypertension in Pakistan, hypertension is kind of, half the hypertensive are actually not hypertensive. They've had one blood pressure reading and they've been put on Tenormin 50 milligrams, and that's what they're taking. But in my opinion, they don't have hypertension. So I think unless somebody has really serious hypertension, I wouldn't.
No, but
personally won't worry.
I think that's true for UK as well, because in UK, the GPs get incentivized for treating hypertension in elderly. And most of the patients are over-treated for blood pressure. When they come to the hospital, their blood pressure is down in their boots. And the first thing I do is stop their antihypertensives and observe them, because on the ward, their blood pressure gets checked every 4 hours anyway. So if they're hypertensive, it will come up. So that's,
Do you have any patient with blood pressure down following?
Yeah.
Preparation?
Well, I think that's a big problem usually. I mean, something which we always tell people, that when they are taking bowel prep, they tend to become dehydrated with it as well. And they can, as a result, become hypotensive, dizzy, fall at home as well. During the procedure, their blood pressure can fall, number one, due to vasovagal syncope, because when you are manipulating the scope inside their bowel, they get a sudden vasovagal syncopal attack. And normally, you monitor their pulse oximetry, and we do blood pressure as a routine as well. So if it falls, we give them something like normal saline infusion, or give them atropine if it's vasovagal syncope. So depends on how.
I stop ACE inhibitors, ibuprofen, and benfluoreside 72 hours before,
Yeah, which is a good idea. Yeah.
and then you give them the prep the day before.
Prep, yeah. Good. Right. The other complication, bleeding, which can occur. The general risk is 1 in 500, but after a polypectomy, it is higher, as I said, 1 in 100, maybe, depending on the type of polyp you remove. So, if you are lucky, you will see the bleeding immediately, and then you can treat it immediately as well. What we normally do is, if I can find a bleeding spot, it's easy to clip, we can clip it, or use a heater probe on it, fine. Sometimes, if the bleeding is massive, you can't see it, then it's a good idea to inject some adrenaline all around that area and wait. Because when you wait, the adrenaline will cause local vasoconstriction and ischemia, and it will cause blanching of the area and clearance of the blood. So you wash that off, and then you can locate the bleeding spot and treat it more comfortably. Normally, if you have bleeding immediately, it is not a problem to control it. So if you can't control it, then of course you have to depend on your friendly surgeon. Very rarely, normal. Again, you can get delayed bleeding up to 72 hours or even up to 10 days post-procedure, and that can be a problem. It is always important to make the patient aware that they can bleed a week to 10 days later as well, so that if they find any blood or they become dizzy, they should know what to do. Some polyps are at particularly high risk for bleeding. For example, if they are a big, chunky pedunculated polyps with a large stalk, then that means they've got a big feeding vessel going into it. Now, those polyps should not be removed by a novice or a standard, a colonoscopist. They should always be referred to somebody who knows what he's doing and who's an expert in the procedure, because you may need additional equipment like putting loops around the stalk or the clips. I used to do that, but nowadays I've stopped doing it because it's too much hassle. I just remove the polyp and then look for the bleeding spot. But then again, you should know what you are doing. But generally, people would pre-treat those by putting a endo loop around the base of the stalk or clip. Bowel prep again, we discussed it, but just to recap, it can cause, especially the phosphate-based bowel prep can cause electrolyte imbalances. So you have to be, the one that we use there is, the brand name for that is Picolax. I think it's very similar to what you use here. In fact, if somebody has got renal failure, one should be aware of that, because you can cause a toxic hyperphosphatemia. So in cases of renal failure, we do not give phosphate-based bowel prep. We don't give it anyway. So we use our standard movie prep. It can cause hyponatremia, hypotension, and usually frail patients, elderly patients who live on their own, they can develop postural hypotension and can increase the risk of falling at home. So always one has to be aware. So it's always a good idea to know whether the patient has got any other comorbid factors like renal failure or hypertension or anything like that. We use our standard clean prep or movie prep. The problem with clean prep and movie prep is that they are very large volumes to take. Clean prep is 4 liters of fluid to drink, which is horrendous. Movie prep is better because they have half the volume. It's the same thing chemically with an additional magnesium citrate in it to sort of stimulate the bowel. So the volume in movie prep is smaller, and I think the taste is also a bit better. So we tend to use movie prep now. We're using clean prep.
There's an argument to suggest that the citrus-based causes a little after.
Yes, yeah. That again you would see with phosphate-based preps as well. Sometimes you see these small abscess ulcers. Yeah, and those are due to the bowel prep.
The reason why I mention it is that when you go in with the colonoscope, you see these little things.
Yes, yeah. People get excited. Yes. Yes, yeah. Yeah, I used to biopsy them, but then I've learned better. Mispathology. Colonoscopy is the gold standard for diagnosing polyps and other colonic pathology, but it is not infallible. You can, even in the best of hands, you can miss pathology in about 5% of cases roughly. Maybe more in the cases of those who are not so skilled, but still